So I will go on to introduce Chris Hogan now. He's going to be doing the next talk. So has a wide interest in the practical, theoretical and academic aspects of general practice. Currently, he's an honorary clinical associate professor in the Department of General Practice at Melbourne University, being a foundation member of the VIC-REN, a general practice-based research network supported by the department. He is the historian for the RACGP Victoria and deputy chair of the RACGP History Committee, so we'd have lots of interesting things to talk about. He had been a GP in Sunbury since 1979 and principal of a large multidisciplinary general practice there. Of relevance to this talk, he's been a member of RACGP Quality Assurance Committees, a member of the Council of Cancer Council Victoria, member of Cancer Council's Australia's Lung Cancer Project, chair of the Central Highlands Division of General Practice and involved with their Diabetes Quality Improvement Project. Amongst other things, he's been an educator for the National Asthma Council's A-team, which involved him lecturing to GPs, allied health staff in Victoria and across Australia.
And I hope you enjoyed my talk. Thank you very much. Well, my take-home messages are pretty straightforward. But first of all, we need to work cooperatively. Next thing is that we need to provide education. There is more to providing education than just There's more to education than just providing information. Information alone is only part of the process. We need to involve the informal carer when we're doing any education for a patient. The next thing we need to be involved with for cancer control is prevention, screening, early detection, early intervention, post-cancer surveillance, and that's it. That's basically my talk. The rest of it is detail. I'm just about to go through the detail, but you will be sent a copy of my slides. Now, education is more than the provision of information. It's the process of incorporating new information into a person's pre-existing beliefs. And I said beliefs. It's what they know and it's what they think they know. It is an extremely important thing. The word doctor means teacher. So that as teachers, we have to use educational principles to be able to educate our patients. There's not just telling them. We've got 2 ears and 1 mouth. We should use that in that ratio. Basically, we should ask questions before we give answers. Colorectal cancer is as you can see, is the most common cause of cancer-related deaths. When detected in the earliest stages, the cure rate's 90%. Regular screening with fecal occult blood testing is very helpful, as the early, easily treated cancers are symptom-free. Only 40%, now that's the good news, but currently only 40% of cancers are detected early. The rest are detected when symptomatic and therefore at late stage. Oh, poo. As I said, prevention, screening, early detection. The diagnosis is basically done by the GP or specialised services. In treatment, the GP is part of the multidisciplinary team, and if they're not, they should be. Certainly this is something that Cancer Australia is very, very keen on. Now, the other thing too is post-cancer surveillance consists of dealing with dealing with people afterwards, because the risk of recurrence, other cancers or complication of cancer or its treatment is very possible. And currently no one has responsibility for that apart from the GP. The groups, the hospitals are getting a little bit better at it, but with the leading towards multidisciplinary teams are getting a bit better. Survivorship is an issue, and of course, on the other hand, we have palliative care, which is often managed by GPs in association with PAL care teams. It depends on your location, of course. My responsibility is to the whole of Victoria, but basically we do most of our lectures to the urban and inner urban areas, and that's a bit useless. Now, the other thing too is when we're talking about cultures, we're talking about people coming in from other countries. Well, the thing is that even in our own culture, chronic illness has only existed in Australia for the last 2 to 3 generations. Think of it. chronic airways disease, when you live in a subsistence community, what happens to you if you can't work? You die. What happens if you've got asthma? You die. What happens is if you've got arthritis? You die. What happens if you've got tuberculosis? You die. What happens if you've got tuberculosis? Anything along those lines. I was in Italy once at a place called the City of 1,000 Steps. They lied, it's 2,000. And we saw this little old lady going tick, 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 tick up the steps. And she had in her hand a stick and a bag of groceries. In the other hand, she had a shopping trolley, and she'd go tick, 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 tick. My wife said, well, give her a hand. I said, just wait. And sure enough, 10 minutes later, there she was still going up. We caught up with her later, unfortunately, because we could speak Italian. We said to her, Signora, what happens to the people who can't walk up there? Oh, they die. But what happens, the sad part about all that is there is no understanding or folk health information from the normal carers about ongoing illness that requires ongoing patient management, particularly in traditional groups, whether they be Anglo or otherwise. All right, your patients are sick. Who do they ask first of all about what they do with their sickness? Go on, you've got tongues? Shout out. Who do they ask? Johnny or Giovanni has got a sore throat. Who does he speak to? Who does the mother speak to? It depends on the community, but if they've got an established community, it's usually the grandmother, and it's usually the maternal grandmother that they speak to for knowledge. But basically what happens is, we were talking before about how information has changed. What's the use-by date of medical information? If I tell you something today, for how many years can I guarantee it? Come on, give me a number. Cynic. Give me another number. Okay, the universal answer to any question in medicine is it varies. Yes, you're right. It's about 2 to 5 years. So the thing is, we need to tell our patients that their medical information has a use-by date. Because what happens is, I was told 10, 15 years ago I didn't need another pap smear. Great, fine, that was true then, but it isn't true now. Okay, the informal carer obviously may know nothing about chronic illness, and they will say to me, when you go into the Aboriginal communities and you say, you've got such and such, doc, how about an injection or an operation to get rid of it? If you go into the traditional Irish or Celtic communities and you ask them, their prayer is a full recovery or a quick death. There is no middle ground. We are now in the days of the middle ground, and our cultures, our usual caregivers, our usual grandmothers, the yaya, the nonna, the nunu, the uma, they know nothing about chronic illness or its management. Similarly, preventative health screening is relatively new, and the community health literacy, I think it's in the book, it says that 60% know sweet precious little about health literacy. I would say that whoever wrote that is an optimist. I would say that even among health professionals, health literacy is not good outside of their areas. And there is no point in educating a patient unless you provide education to their informal carer as well, provided one exists. Because often our communities are so mobile. I mean, my family is spread from Albany and WA to Brisbane. And, that's it. It's usually mum, the missus, or the grandmas, the person who provides emotional and practical support and health advice to the patient. They can be your best friend if you involve them, or they can be your worst enemy. And I have seen children die because the informal carer did not believe what the doctor was saying. Guidelines are guides. They have their limitations, That's a whole talk in itself. What we hope to do is to provide you with information that is useful to you and your patients. We will hope that you will develop the processes that will optimise patient outcomes in your practices. Now, the other thing is when you develop it and you come up with an idea and no one else has had the idea, don't be afraid. Someone has to think of it first. Why shouldn't it be you? There isn't always someone else who's got the same idea. Because with Richard's idea of the new receptionist, sometimes you can think it. Sometimes people can come up with an excellent suggestion. There's no copyright in common sense. Just wished it was copied a bit more often, as a matter of fact. Colorectal cancer is a condition in which family history is important. When a patient is diagnosed with a cancer of familial significance, it is extremely important that the other members of the family be contacted. That's logical, isn't it? Is it? Is it logical? Does it happen? No. I think I found a way that you can improve your cancer detection rates. The family history must be regularly reviewed, because how often does the family history change? Come on, guys. How often does the family history change? Regularly. It varies. Now, the cultural attitudes to health. Now, this is based on some work by Justin C, and obviously he concentrated on the Chinese, but I think it applies equally to a whole range of... any traditional culture will have its specific attitudes, but you can see, we believe in health, not in promoting our health, rather than detecting hidden disease. The Italians, if they don't see it, it's not there. Fatalism and low belief in screening. Health seeking is based on symptoms. The idea of looking for something that isn't there, that doesn't produce symptoms, doesn't exist in many cultures. Why? Because they're traditional cultures and they don't have the cultural experience of chronic illness. Now, even in Australia, it's only existed for the last 2 or 3 generations. As a historian, I can tell you about the massive effect that we had with the introduction of the antibiotics into Australia. When did antibiotics become widely used in Australia? What year? Give me a guess. Come on, guys. When were they first used? Cynic. Do I hear better? They were first used in 1945. Penicillin was first available in 1945.
Chris, I'm just gently nudging you towards the microphone.
Oh, sorry. So it's 1945. But there you see the importance of the doctor recommendation and explanation. And as I said, when you're explaining to someone, before you open your mouth, open your ears, ask them, what do you understand is happening? What do you think is happening here? What do you understand by asthma? What do you understand by cancer? What do you understand by da-da-da-da-da-da-da? Ask them. The reasons for poor participation in screening is limited knowledge about bowel cancer. I would just leave it as limited knowledge. It's an unpleasant test. It's not unpleasant, it's just a poo test. And really, I mean, anyone who's a parent, a modern parent, i.e. over 1960, is often used to changing crappy nappies. You don't even get your fingers dirty, for God's sake. There's the fatalistic views about cancer. They think it's untreatable. They think it's God's will. Well, inshallah, that God has sent us here to be able to do something about it. And the shame and privacy, which is more traditional, which is more common among the ATSI, the Aboriginal Torres Strait things, whose concept of illness and disease is often based on... It's often extremely complex, and for a culture that's built for well over 18,000 years, even the idea of sex causing pregnancy is not widespread. in the traditional society. If you want to talk to me about spirit babies, I'll talk to you about that later on. In successful programs, the GPs, this is the personal experience of the interventions. The GP gives their support and encouragement, but many active interventions are undertaken by the nursing administrative staff. In other words, the doctor says yes, and the people who do the work very effectively. So it's basically a cooperative thing. It's a matter of looking at the whole range. The book goes through the vast majority of techniques that can be used. The consultation is often jam-packed with the priorities of both the GP and the patients, the GP reacting to the patient's priorities. So it's important to be able to structure. Non-doctor staff find it easier to follow protocols. I did say that politely, didn't I? Thank you. If a process can be standardised, it can be computerised, automated or delegated. So the idea of whole of practice work is very important. With the Plan, Do, Study, Act cycle, a whole of practice consultation is essential. I've worked in a lot of teams in a whole range of nasty areas, and I often find that some of the best ideas come from the most unexpected areas. There is no copyright and common sense. If you want to know how a job functions, ask the person who does it. Don't never assume. Please never assume. One of the studies that we did was we looked at what practice nurses did, and then we compared it with what the practice doctors thought they did, and there was very educating. Okay. This is looking at 5 system reviews and looking at audit and feedback. More things are missed by not looking than by not knowing. And the other maximum is that the truth makes liars of us all. If you don't look, you don't find. So just doing audit and feedback, you increase your screening rates, breast by 14%, cancer cervix by 9%. This is prior to Gardasil, and colorectal by 13%. The office symptoms prompts are often useful. The increased screening uptake was, you can see, was increased by 23%. GT endorsement of screening invitations is extremely important, especially in CRCs, colorectal cancers. The practice organisational change is extremely important. I don't need to go over that. This is an example of an invitation that was sent out, and this leads to a 6% increase in participation rate. Better if the GP signs it electronically, different from the signature you use on your cheques, please. And there's the potential to implement... No one laughed, didn't you hear? Anyway, doesn't matter. Potential to implement screening based on birthdays of at-risk groups. All right, these are the survival rates. You can look at that later on. But the prevention of bowel cancer is actually, there is prevention available. First of all, we know that diet is extremely important. Low fat, high fibre, broad-based soluble fibre. Exercise, very important. The other thing too was weight and abdominal girth, smoking cessation, alcohol reduction. The role of aspirin is under investigation at the moment. There's a big trial which we expect to have the full results by 2022. Screening programs are based on asymptomatic patients. Now, as I've said already, culturally you're in a barrier because a lot of people do not culturally have an understanding of preventable illness. It just doesn't exist. And it's not that their knowledge is wrong, it's just not appropriate for modern times, or for the times in which we find ourselves, to be truthful. Whether it's an improvement or not is another story. Now, the other thing too is if a patient presents with symptoms or signs, a thorough history and examination, including PR examination, you don't stick your finger in it, you stick your foot in it, should be performed and the typical presentations include changes in bowel habit, rectal bleeding, unexplained loss of weight, iron deficiency. Iron deficiency is a symptom, it is not a diagnosis. If you have someone who's iron deficient, you want to find out why. And abdominal pain, of course. These are the cancer guideline wikis, which you can see it if you're interested. But the thing that I really pushed it up is I've been heavily involved with with GISA on the formation of, this is a program for laptop and desktop computers, IBS for GPs, which looks at the diagnosis and management of irritable bowel syndrome. Very important. We now have technique of being able, 95% accuracy in diagnosing irritable bowel without colonoscopy, and we have a 90% efficiency in treatment. It's a lot better than anything that's been there before. Bowel screening initiative, as you can see, has just recently been started. It's effective, but once again, it's got a low uptake. Once again, you'll get a copy of all these slides. This is just for the highlights so you know what to look at. This talks about from 2020, all Australians between 50 and 75 will be having a two-yearly screen. We estimate that we'll save about 500 patients annually, 500 years annually. Sorry about that. And significantly reduce the burden of cancer in Australians and the family. But to do it, we need your help. These are the guidelines of screening. Now, this is more focused screening other than just randomised population. Basically, we're drilling down on individuals. So we're looking at family history, and we're talking about category 1 and the higher categories. So this is basically just to mention them. Category 2, and you're looking at basically people who are at risk of those who have one first-degree relative with a cancer diagnosed under 55 years, or 2 first-degree relatives with cancer diagnosed at any age, or 1 first-degree relative and at least 2 second-degree relatives diagnosed at any age. All right, the issue that we have here is that there's a high incidence of non-parenting in Australia. I think the incidence of a person whose daddy ain't the daddy but the daddy don't know is running between 2 to 5%, depending on the population at which you go. So relying on family history is often an exercise in optimism. And this is one of the areas where we hope that the DNA analysis of the human genome is actually starting to improve. So we will get somewhere. This talks about the very high risk, and basically, as I said, this is just basically for you to look through at some stage. And these are where your resources will be. Screening for colorectal cancer is part of the cancer continuum, and the general practices should be proactive. It really does make a difference. Early detection is critical. The role of family history. It takes time to clean your data, right? Taking a history and looking at, these days every time a patient turns up we ask their date of birth, just so we can be sure it's actually them. It makes the same thing when it comes to cleaning up the family history and the past history. One of my jobs used to be looking through these sort of things for medical legal purposes, and I'm terribly sorry, but they're crap at the moment, just hopeless. You actually, in my practice, what we did was we dedicated a month, a year, where everybody who turned up would have their history reviewed. They'd be given a printout of their history summary. We're saying, is this information accurate? Is this information complete? Is there any information in this which you wish to keep private, just to the practice? And is there anything you wish to add? It was amazing how much work we had to do just to do it. It is really an intense work.